Okay, welcome to part 3. Understanding why side effects matter with dopamine blocking or antipsychotic drugs, and how we can think about those side effects to influence which drug that we choose. So what should an antipsychotic do, and how long should we wait before we expect it to do its job? Well, like all drugs, there is sort of a span of time. Some of these things we can expect to happen fairly early on in the process. Other things are going to take a longer period of time. So I've broken down our expectations on a temporal line here. So at the very beginning, we should see some reduction in agitation and fear. While people with acute psychosis can often be frightening to us as clinicians, we have to remember that often they are very afraid as well. And often they're afraid because of the distortions that the psychosis is causing in their brain. So they may be thinking that people are trying to kill them, and that's why they're agitated. They may be thinking that your hospital is a prison and they're being locked up. So what we want to initially do is help the person calm down. And usually that is related to some decrease in the intensity of the delusional material that they may be presenting with. And we can expect this often within the first few doses of medication, sometimes even with the first dose. We want to have a goal of decreasing the auditory and if there are visual hallucinations, which are much less common, but decreasing the hallucinatory material by at least a third. That's a reasonable goal in the first few days of treatment. And hopefully along with that comes with decreased paranoia, decreased intensity of affect and presentation, and decrease in anxiety. We're hoping that as time goes on, usually we're now looking in the sort of days to weeks rather than hours to days span. So this is as we're moving into sort of weeks and maybe even first month, decreasing confusion, hopefully having some improvement in thought organization. And that leads to an improved functional ability, the ability to interact with other people, and hopefully being able to get back to doing things like going to school, working, getting along with other people in your household. Ideally, this makes it easier for somebody to move from an inpatient setting to an outpatient setting. And, the hope with these medications when deinstitutionalization began was that they would prevent the need for custodial care and prevent such sequelae such as homelessness. Again, I think it's a matter of debate how successful those have been, but that is one of the goals that we have here. And then finally, as time goes on, some improved cognitive organization. Now you can see this is really, you're not going to start to see some of these later effects until you're several weeks into the trial. So somewhere like 4 to 6 weeks is considered a full trial of a medication, both for efficacy and early tolerability. Now, full efficacy, you may continue to get benefit with prolonged treatment, and this is where the long-acting injectables can be particularly helpful, which will be talked about by my colleague in the next set of lectures. But with this, this is also when we need to start looking at long-term tolerability monitoring, things such as changes in metabolic measurements and such, which can sometimes happen later on, several months into treatment. Okay, let's talk about safety. All antipsychotics have what's called a black box warning with regard to treatment of geriatric patients. There is an association that is not terribly well understood that there is about a 1.6 times increased risk of all-cause mortality in elderly patients that are treated with antipsychotics. Does that mean we never treat older people with antipsychotics? No, but it means that we have to have a conversation with the patient and the family, particularly the family, if we're treating somebody who has psychosis related to dementia or behavioral problems related to dementia. And we want to think about using antipsychotics later rather than earlier in the treatment of that. We want to think about changes in the environment, circadian rhythm training and such to try and avoid confusion with people with dementia rather than reaching for an antipsychotic as a first-line treatment because of this increased risk of all-cause mortality in elderly people. All right, so side effects, let's break them down into specific families of side effects. So the extrapyramidal symptoms are caused by that dopamine blockade in the niagara striatal pathway. We use this term extrapyramidal symptoms. It refers to the tracts that are the pyramidal tracts that are outside of the pyramidal tracts. So it's one of those neuroanatomy terms that's kind of self-evident, but a little bit obscure. So extrapyramidal symptoms are things such as Parkinsonian symptoms. So if you think about somebody with Parkinson's, you're going to think about somebody who's got rigidity. Maybe they've got a forward-facing posture, with a little bit of a lean. They may have a resting tremor. They may have a very masked or flat face. Blunted. They have emotional blunting. They may have cogwheeling, which is when you the way you test for cogwheeling. So you ask the person to relax their arm as if you're going to take their blood pressure. You put your thumb on their bicep tendon, and you passively move their arm using your, obviously I don't have another pair of hands here, but you move their arm back and forth like this. And if you feel this kunk, 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 kunk in that bicep tendon, that's what we call cogwheeling. And that is a Parkinsonian symptom that can happen with these strong dopamine blocking drugs. Acute dystonia is something such as torticollis, which is twisting of the neck, or an oculogyric crisis, where the person's extraocular muscles will spasm, causing their eyes to roll up into their eye sockets. It's known as an oculogyric crisis. These are fairly rare, but they usually happen, if they're going to happen, within a couple of days, usually no later than 4 or 5 days after starting typically a strong D2 blocking drug. If it happens, it is considered an emergency, and you're going to treat this with intramuscular benzotropine, which is cogentin, or diphenhydramine, which is Benadryl, because both of those have a strong anticholinergic effect and can reverse the effects of this. I actually have only ever seen torticollis and an oculogyric crisis once in my entire career, and it was when I was touring a large psychiatric hospital in Havana, Cuba in 2004. I was there on a UCSF trip, and actually saw somebody in an occupational therapy. It was literally basket weaving, and this patient who probably was on something like haloperidol was being led into the nurse's station with her neck. So this is a spasm of the sternocleidomastoid muscles, and her eyes had rolled up into her head, and she went into this closed room. They probably gave her an injection of benzotropine, and 15 minutes later, she came out just fine. So that's actually the only time I've ever seen that kind of acute dystonia in my career. So it's pretty uncommon. You might see it more if you're working in an emergency psychiatric setting. And then we want to talk about akathisia. So akathisia is an EPS. It's different than Parkinsonian symptoms. And this is a very common problem. About 25% of people on antipsychotics will experience akathisia. And it's often misdiagnosed as agitation, because what akathisia looks like, you can probably remember having akathisia even if you've never taken one of these medications. If you've ever been on a long plane ride or sat through a long movie, and you get to that point when you're about to get off the plane where you're just like, I just want to get off and move. I just feel this like internal restlessness, like, come on, let's go. And it's not, not because you're late to get your connecting flight, but you're physically relieved by movement. And this is what akathisia feels like. So it can present as a physical kind of restlessness, kind of jumpiness, or it can feel like just an internal kind of agitation. This is often responds very well to propranolol, beta blocking drug. And we want to use reasonably good doses of this, and typically the extended release form. So 60 to 120 milligrams. So given at night is a good way of treating this akathisia with dopamine blocking drugs. Typically dose that at bedtime, as I mentioned. And of course, since it is a beta blocking drug, we want to make sure that we're monitoring somebody's blood pressure and heart rate, because that is a high enough dose to affect those parameters. Historically, this was treated with benzotropine or cogentin, but that is increasingly sort of falling out of favor, because as you can imagine, blocking acetylcholine receptors in people that are already struggling with cognitive problems as a result of schizophrenia can only add to that problem. And benzotropine is an anticholinergic medication. So generally, we want to treat akathisia with propranolol and not cogentin, excuse me. All right, let's talk about some of the metabolic side effects of these medications. So the the great thing about the second generation antipsychotics is that they markedly reduce the incidence of movement disorders caused by these medications. What the trade-off is that they had a lot of side effects that affected metabolism and led to weight gain and led to the sequela of obesity, such as diabetes and cardiovascular risk. So this is generally not something that happens overnight. You're going to see this happen gradually with gradual weight gain and increases in insulin resistance and hyperlipidemia. So we're going to want to monitor that with these second generation medications. In general, the newer medications of the second generations, because remember, the second generation antipsychotics, the first one came onto the market in 1989. So we're now, looking at 30 plus years since the introduction of these medications. And the newer medications that have emerged in the last, I would say, 15 years or so are much more metabolically neutral than some of the earlier medications. The downside is they're often quite expensive. So the worst of these offenders are the ones that have a strong blockade on the histamine receptors, so H1, and the serotonin 2C receptor. Clozapine is absolutely the worst offender in this, followed fairly closely by olanzapine or Zyprexa. These other medications have a little less of this problem, but they still can cause some metabolic disturbance. The exact mechanism of this is not totally well known. I have added aripiprazole onto this because aripiprazole or Abilify came out around 2002, 2003 or so, because the ones that came out in the 90s were really problematic with regards to metabolic stuff. Probably the exception to that would be ziprasidone or Geodon. But aripiprazole kind of came out and said, hey, I'm the new kid on the block and I don't cause these metabolic disturbances. And as time has gone on, it's become clear that that's not totally true. So I've added aripiprazole to the list here because there's some more recent data that indicates that it actually might be just as bad, if not worse, than quetiapine or Seroquel, which is pretty well known for causing metabolic disturbance. Now, most of the time, this is going to be a gradual process. You're going to see this slow increase in fasting blood glucose or elevated hemoglobin A1C, and also the early markers of hyperlipidemia, which is increased fasting triglycerides. You can have a sudden onset of this sort of diabetes sort of presentation and DKA or hyperglycemic hyperosmolar syndrome. And that is a real emergency, obviously, that happens. Fortunately, it's fairly rare, but it's something to know about. I consider any kind of rapid weight gain with these medications, such as more than 5 pounds in a month, as a pretty big red flag, especially if that's starting to happen early on in treatment, because that problem can often continue well into the future, creating some real metabolic disturbance. So we're going to want to monitor for this. This is standard of care. So you need to be keeping track of this with your patients who are on these agents. We always want to start with baseline weight. We want to ask about family history of metabolic disease, such as diabetes and heart disease. We want to get a waist circumference because it is adipose tissue at the abdomen that is more metabolically active with regards to diabetes. We want to check on their blood sugar, either as a fasting glucose or a hemoglobin A1C. We want to check blood pressure, and we want to get a lipid panel at the beginning. Now, you can do this a couple days into treatment. That's fine. So if you want to start the med and then send somebody for labs later in that week, that's fine. But you want to then monitor those labs at the 12-week mark and then quarterly going forward. Annually going forward at that point. So if you're going to see disturbances, often you will see them at that 3-month or 12-week mark. And then you're going to want to keep track of this every year going forward. The aims, I'll talk about in a moment when we talk about movement disorders, but that is something that you're going to want to monitor with people who are on dopamine blocking drugs. Now, what causes these side effects with regards to such things as sedation and dizziness or dry mouth and cognitive impairment? This usually is due to receptor activity on these 3 different receptors. So the H1 or histamine receptor, when we block that, we get drowsiness, which we know from medications such as Benadryl. Diphenhydramine is well known for causing drowsiness because when we block those receptors in our brain, we get sleepy. That can also contribute to weight gain. Blocking the norepinephrine alpha 1 receptor is what results in such things as orthostatic hypotension, also contributes to drowsiness and can contribute to dizziness as well. So blocking that often will cause sedation that patients will find unpleasant. And then finally, blocking the acetylcholinergic or acetylcholine muscarinic 1 receptor is what results in things such as constipation, dry mouth, blurry vision. And if we block it enough, we get cognitive impairment. And if we block it even more, we can get delirium. I think we all remember from our nursing days what can happen, especially with older people, if they take an anticholinergic med. They can get an anticholinergic delirium. Now, the meds that are probably the biggest offenders in this would be clozapine and olanzapine, quetiapine being a runner-up definitely for things such as weight gain and drowsiness, and then to a lesser extent, these medications below it. Now let's talk a little bit about tardive dyskinesia. So tardive means late, dyskinesia means abnormal movement. And the pathology of this is related to blocking those D2 receptors in the nigrostriatal pathways actually leads them to be what we call upregulated or supersensitized. So they actually become, because they've been blocked, the ones that are there have to become very sensitive. And through a mechanism that is not totally clear, leads to these repetitive stereotyped kind of movements like you're seeing in these little video clips here. Now, people with schizophrenia may actually be at a higher basal rate, risk rather, for developing tardive dyskinesia, which is only worsened by chronic dopamine blockade. This used to be a much bigger problem when we only had first-generation antipsychotics, and it was thought that about 5% of risk per year. Most of it weighted really in the first 5 to 10 years of treatment. So if somebody was on a strong D2 blocking medication such as haloperidol for say 10 to 20 years, it was almost 100% chance that they would develop tardive dyskinesia. And as you can tell by looking at these videos, these are pretty stigmatizing behaviors. A lot of times I think people think that people with schizophrenia exhibit these movements just naturally, and these are caused by drugs. So this is a iatrogenic phenomenon. The second generation antipsychotics do confer some risk for tardive dyskinesia. It's not zero risk as it was originally purported to be, but it's several factors less than the first generation antipsychotics. So I've read that so haloperidol, for example, is 12 times more likely to cause tardive dyskinesia than say something like olanzapine. And it's also worth remembering that some of the drugs that we use to treat chronic nausea, such as promethazine or Reglan, taken chronically can also cause tardive dyskinesia because they are blocking dopamine receptors. We want to be doing something called the AIMS exam, which stands for the Abnormal Involuntary Movement Screening Exam, on a regular basis. There's a video link here, which I will put in the resources for the class. So this is a short video. It's about 7 or 8 minutes that will walk you through how to do an AIMS exam. And you can find the scoring sheets pretty readily on, that's from Up to Date, but you can also just Google it and find it. For a long time, we really didn't have anything we could do for tardive dyskinesia. Once it started happening for many people, it was quite permanent. In recent years, there has been the development of several drugs, or 2 drugs on the market now, that are known as VMAT inhibitors. So these are vesicular monoamine transporters. So these are structures within the presynaptic cell, which moves the dopamine, in this case, so that'd be the monoamine we're talking about, but there are VMATs for other monoamines such as serotonin and norepinephrine. It moves them into the vesicles, those little prepackaged bubbles, if you will, that are full of neurotransmitter ready to be released. So by doing this, you actually decrease the amount of dopamine transmission, and you can see some modest benefits in this. The average is about 3 points on the AIMS test, which is not a lot, but it can be the difference between somebody being too disabled to say work or go to school and be able to function in those roles. The downside is these meds are quite expensive. They run sort of $40,000 to $60,000 per year. So getting coverage for them can be quite difficult. And of course, that creates some real cost issues for the healthcare system. So it's good to have those available, but it is important to recognize that they do come at a significant cost. Neuroleptic malignant syndrome is a fairly rare phenomenon. Hopefully you'll go through your whole career and never see it. It happens in less than 1% of people, but it can be a fatal reaction to antipsychotics. And it has this characteristic triad of fever, muscle rigidity, which leads to increased creatine kinase, and autonomic dysregulation. So fever being part of that. And people are invariably delirious and altered in their mental status when this happens. This is not something you're going to treat as an outpatient. You need to get this person to an emergency room because they often need such things as IV fluids in order to preserve their kidneys with that much creatine kinase floating around. And they also need reversal drugs such as dantrolene or bromocriptine. So this is going to be done in an inpatient setting. It's very important to get people care for this right away, should you ever see it. We'll talk more about pregnancy and women's psychiatry and pharmacology in the next quarter. But I do want to just give you a little bit of preview of coming attractions that in general, second generation antipsychotics are considered relatively safe in pregnancy with regards to teratogenicity. So we always want to do a cost benefit analysis of what's the risk of taking a mom who has, say, a disorder such as schizophrenia off of an antipsychotic while she's pregnant, which is obviously a higher risk time, versus the potential risk to the developing fetus. And the consensus statement, these are the folks at Mass General. If you could look at womensmentalhealth.org, great resource. They published this paper a few years ago in the American Journal of Psychiatry, essentially saying that the risk for birth defects is quite low. So which antipsychotic should we use? Are they all the same? Is it like antidepressants where you just pick one or base it on side effects, or how do we do this, right? Is there a most effective medication? Well, there's been a number of attempts to try and answer that question. Probably the classic query into this is now 16 years old, but this is the Katie trial. So what they were looking at here was essentially just a very simple question of how long will people stay on their antipsychotic medications, people with schizophrenia? Because we know that that's a classic problem with people with schizophrenia is they stop the medications that they're taking. So this study, which was a large study, started people on antipsychotics, got them stable, and then followed them to see how long they stayed on it with that idea of all-cause discontinuation, which is what that's referred to as being a sort of a ballpark understanding of tolerability. And interestingly, what they found was that olanzapine and perfenazine, which is Trilofan, which I'll talk about in the next module, were actually the two most tolerable medications, which was quite surprising because everyone knew that olanzapine caused a lot of weight gain and metabolic disturbance and was pretty sedating. And the perfenazine was sort of thrown in there as a little bit of a straw man because it was the only first generation antipsychotic in the study. And so it was really surprising to find that patients didn't mind taking it because we were all told back when the second generation antipsychotics came out that like, oh, those old meds that you're taking, they're so primitive. There's a reason why nobody wants to stay on them because they're awful to be on. And you should give them this new medication that costs $10,000 a year. So it was quite a surprise to find out this medication that costs, maybe pennies per dose was actually just as tolerable as these new fancy kids on the block. So there's been a number of different ways of trying to parse this data. Obviously, I'm not going to go through this chart in detail, but this is going from looking at different parameters such as efficacy, movement disorders, sedation, and then rating them. The top of the chart there are the things that are more likely to be tolerated, and the things at the bottom are the less tolerable. And so sometimes things that can be fairly effective, such as clozapine, are often more difficult to tolerate, from a standpoint of, say, sedation. So those are on opposites. So clozapine is the least tolerable with regards to sedation, but the most effective, the medication. So this is all things that go into your thinking when you're deciding on what medication do you want to use for a patient, or what medication do you want to include on your desert island kit. Let's look at effectiveness. So this is called a forest plot. So the closer your dot there is to the right, where that 0 is, the less effective it is. So this is arranged from least effective at the bottom to most effective at the top. So you can see that clozapine hands down beats the rest, which is great. Why not put everyone on clozapine? Well, we'll talk about that in a minute, but there's a lot of side effects that go along with clozapine. So this is the sort of Faustian bargain you have to make when you're deciding on a medication, that the most effective medication might be the least tolerable. And some of the more tolerable medications may be less effective. So we're always trying to sort of run that calculus in our mind with each patient when we make a decision about the medication. But you can take a look at this data for yourself. So what's the best antipsychotic? Really, the one that works, that the person will take, that doesn't cause any more side effects than is necessary. That is the best medication for your patient, and that will not be the same medication for every patient. That's the key thing to take away from this. All right, I'll see you in the next talk where we talk about first generation antipsychotics.